I'm Dean Keriakes, Deputy Editor of the Journal Society of Cardiac Angiography and Intervention, and President of the Price Hospital Heart and Vascular Institute in Cincinnati, Ohio, and Professor of Clinical Medicine at The Ohio State University. I'm here today with Dr. Yousif Ahmad, who's Assistant Professor of Medicine at Yale University School of Medicine, and is first authored on a paper entitled PCI and Heart Failure, Current Evidence, Impact of Complete Revascularization, and Techniques to Improve Outcomes. Joining us today is Dr. Mark Petrie, who's professor at the Institute of Cardiovascular and Medical Sciences, the University of Glasgow, UK. I'd like to start by asking Dr. Ahmad if you could briefly summarize the magnitude of the problem, ischemic heart failure, revascularization strategies to address this problem with a focus on PCI, and possibly future directions. Dr. Ahmad?
Thank you very much, Dr. Keriakes. So we know that ischemic heart failure is a colossal problem. It's a real public health concern. Ischemic heart disease and coronary disease is the leading cause of heart failure. And despite this, there's a minority of patients who undergo testing for coronary artery disease, and an even smaller fraction who ultimately undergo revascularization. We have, broadly speaking, two strategies to revascularize these patients. One is coronary artery bypass grafting, and the other is percutaneous coronary intervention. The main strength, I would say, of coronary artery bypass grafting is that we have a randomized controlled trial demonstrating reduction in all-cause mortality at 10 years versus medical therapy alone. So we know in a randomized trial that CABG reduces mortality. I would say, that's clearly the main strength of that modality. And, the main limitation of CABG is that despite this very strong evidence that we have, a very small minority of patients with heart failure ultimately undergo CABG. There is some data that suggests patients hospitalized with heart failure, just over 1% of them will undergo CABG within the 90 days of their index hospitalization. And there's other data that suggests, patients with heart failure are amongst the least likely to be offered revascularization. Part of this is, I think perhaps patients or physicians being unwilling to accept an upfront hazard with CABG. We saw from the STITCH trial that mortality was actually less in the medical therapy arm for the first 2 years. And you really have to have long-term follow-up to accrue the benefit over time. It raises the possibility of whether we can look at alternative revascularization modalities, such as PCI, which might be less invasive, might have a less upfront hazard, but still needs to be tested in a randomized controlled trial. So we don't have that evidence yet. But, the landscape of evidence for revascularization for heart failure is hopefully going to change over the coming years with, generation of new trial evidence.
I think that's fantastic. And to listen to you talk, I'm struck by when you originally saw the original syntax trial data, PCI and CABG. Some point that Keith Dawkins made years ago, I think it was published by Head with 3-year follow-up, is that the between center variability in outcome for MACCE far exceeded the difference, if you will, between PCI and CABG for the trial as a whole. And this really brought the point about specialized centers of excellence and expertise, which I think, Mark, I'd like to ask Dr. Petrie and Dr. Ahmad, you're part of a mega trial. It's taken 9 years or so of follow-up, which is another point we'll talk about in these trials, is the durability, the concept of non-proportional hazards when you actually see survival curves cross in follow-up. How do you pick centers to do this, and what level of expertise? I mean, this is, you cannot cast your net widely because of the hazard of the interventional procedure, be it CABG or PCI.
Yeah, so that's a fascinating issue, and I think we need to put ourselves in the patient's shoes, and we need to be confident that anybody taking on these procedures has got sufficient skills. So when we have performed the trial, which we should touch upon, which is called the REVIVED trial, so REVIVED trial, that's been performed in the UK only. And it's been performed in high volume centres in the UK with really high volume specialist operators. And even within the high volume centres, really specifying that these procedures are done in the hands of highly skilled interventional cardiologists. We need to remember that people with heart failure don't have a mid-right coronary type A lesion. They've got lots of complex coronary disease, chronic total occlusions, bifurcations, small caliber vessels. So these procedures are not the kind of procedures you do in 20 minutes. They take focus, dedication, concentration, and sometimes 2 or 3 sittings to achieve complete revascularization. So the answer is we must encourage the different volume operators to hand these cases over to people who really have true expertise. So in the UK, we had about 10 to 12 very high volume centres. We recruited 700 patients. And that's quite an undertaking for a strategy of revascularization against medical therapy. So PCI against medical therapy. And for a patient to accept that randomization is pretty remarkable. So we concentrated on these sites and we've delivered this trial. As you say, it took 9 years to get to database lock, and we're just locking the database at the moment, and we're going to present at the ESC. So I suspect that'll be majorly influential trial in cardiology. But going back to Yousif's point, it's bizarre that we're now in 2022 before people are doing randomized trials in the area where there's dramatic question about the benefits of revascularization for these people with bad left ventricular function, really low EFs and high peri-procedural risk, and to try and balance that peri-procedural or short-term risk against good outcomes. And of course, we're very happy when we see patent coronary arteries, and we're really keen to know the long-term impact of complete revascularization of these patients.
You've raised several points, and one is how important is the presence of angina, for example, as a clinical indicator in predicting response? Is viability enough? Do you need to show ischemia? And did all of your centers then have CMR and PET scanning to be more accurate in demonstrating the presence and quantitation of ischemia?
So that's fascinating. So when we did the STITCH trial, we did a secondary analysis looking at the presence or absence of angina, and the presence or absence of angina had no impact on the benefit in terms of all-cause mortality. So clearly you relieve angina if you have angina, but people without angina had the same benefit in terms of long-term outcome. So for our trial, we mandated the presence of viable myocardium in the area supplied by the vessel that you were going to intervene upon. But that could be by MRI or it could be by stress echo. There's not a lot of PET, to be honest, in the UK. So the majority were guided by MRI viability, but also some by stress echo. But certainly we need to acknowledge the lack of certainty with regards to viability. Guided revascularization on the basis of the STITCH analysis had lots of shortcomings. It wasn't the answer to whether or not viability has a role or not.
It raised another point that I asked you, Yousif, how good is residual syntax score? Is that measured on most of these people? Do you need to get to 0? It's less than 8, which has been used as reasonable revascularization. Is that adequate?
I think it's a really good point. I think, Mark raised an important aspect that these patients with, ischemic left ventricular systolic dysfunction tend to not have discrete focal lesions. They tend to have complex disease. And so the question of complete revascularization becomes slightly less straightforward. We do have some data that complete revascularization is important. Some people believe that is the primary mechanism by which CABG may have outperformed PCI in other settings, such as multivessel disease. If you look at the SYNTAX trial, the overall complete revascularization definition that was, protocol mandated and predefined was just the treating physician, the surgeon and the interventional cardiologist saying binary complete revascularization had been achieved or not. When you stratify patients in that way, patients who achieved complete revascularization with PCI have the same outcome as patients treated with CABG. So it does seem that based on that analysis of syntax, that getting complete revascularization is an important determinant of outcomes. When it was looked at by an adjudicated core lab post hoc, the residual syntax score did seem to be an important factor. And what that analysis demonstrated is that if you've got a residual syntax score of less than 8, your outcomes were as good as the patients who had 0. If you cross that threshold above 8, your 10-year all-cause mortality was significantly higher. It was 50%. So I think, for especially these patients with ischemic heart failure, we like to sometimes use the phrase, extensive revascularization, get away from people worrying about every last side branch, getting major epicardial coronaries adequately revascularized, good results by intravascular imaging, no significant residual coronary disease, then I think you'll get good outcomes that will hopefully be comparable to those seen with bypass surgery.
Another point that I've raised is the use of mechanical cardiac support in this population. We've obviously got patients that have impaired left ventricular function. How do you choose the patient, or do you protocol drive this, for example? Choose the patient for mechanical cardiac support and then choose the device. Is it the EF alone? Is it left ventricular diastolic pressure, ratio of aortic diastolic pressure to LV EDP? I mean, how do you select? Because I've personally seen kind of a generational difference between younger ICs that are very quick to place mechanical cardiac support and older ICs that will either go with balloon pump or not have mechanical cardiac support. And frankly, there is a hazard associated with those devices, which has been demonstrated. So how do you select the patient and the device?
I couldn't agree more with you that we have to be cognizant of that hazard. Large bore devices, particularly these patients have vascular disease, they have elevated bleeding risk. And so you have to be conscious of the hazard of whatever device you're thinking about. We have to acknowledge that we don't have great data for these devices yet, but hopefully that's changing in the coming years. From a practical point of view, when I have a patient who's got multivessel disease and reduced ventricular function, it's really, a multifaceted approach that, I'll take. The first thing will be, the coronary anatomy. So for example, is there an occluded artery that's not the target? If the patient has a dominant right coronary artery that's occluded and we need to perform left main bifurcation PCI, that's going to put the hazard of the procedure up. That would be one factor. One factor would be the ejection fraction. One factor would be, the type of procedure you're planning to do. I think if you're going to embark on atherectomy, which may have increased risks of either no reflow, dissection, then that will factor into my decision making. And then the last thing that will be, the hemodynamics. And I'll either look at the left ventricular end diastolic pressure, or if there's any kind of borderline equivocal decision, I'll perform a right heart catheterization, look at the right heart pressures, the pulmonary artery saturation, and the output in the index. I think the important thing to emphasize is that the cases that I would use mechanical support in wouldn't have just one of those adverse features. They would need to have multiple of them. So it would need to be, a patient with severely reduced ventricular function who I would plan to, let's say, do an atherectomy of the left main and LAD, had an included right coronary artery, and has poor invasive hemodynamics. I think when you have a coalescence of all of those factors, that will push me more towards mechanical support. If you have, just one or two, I think most of the time you won't need it. And, as a practical point, in borderline cases, I'll obtain, contralateral femoral access with a very small, 1 French inner of a micropuncture and leave that there so that if the patient develops, emergent hemodynamic deterioration, we can put in a device expeditiously without having to, start to get vascular access. So those are, some of it's a complex decision, but those are some of the things that I would look at from a practical point of view.
But, this is an important question. How do you advise your investigators on appropriate utilization, not overutilization of mechanical cardiac support? How do you pick the patient and then pick the device? Because we now have a variety. Any comments, Mark, that you would like to add?
Yeah, I think Yousif has summarized it very nicely. It's people that you feel very uncomfortable about the PCI and you anticipate problems during the PCI. So I think Yousif's answer was excellent. I did want to mention one other trial, which is also happening, just starting in the UK, which is a trial of Impella against no Impella. It's called BESIS-3 CHIP. So that's randomizing people who the kind of profile that Yousif has described with severe left ventricular dysfunction with complex coronary disease and also comorbidity that we're anxious about. But frankly, randomizing people to either Impella support or no Impella support. So that'll again be informative. And I think we are duty bound as a cardiology community to conduct these trials, or we won't know in the future what the role of these trials is. So really keen to advocate design and enrolling, as we are our Cabbage against PCI trial, which is this international trial, which we're doing between 9 countries, funded in Canada, Denmark, and Sweden. That's straightforward Cabbage against PCI, and PCI can be supported by various devices. I think one other thing I would really like to stress is the role of ECMO in PCI. And I think a lot of people misunderstand the role of ECMO. And we see people thinking that ECMO provides left ventricular support, which of course it doesn't, because we actually increase afterload, and we have to be really careful with ECMO. It's obviously a good salvage procedure in people who are otherwise dying, but it really is not a support device. And this is really misinterpreted by people who don't quite understand what you're doing with respect to ECMO. So I would urge people not to think about ECMO in the same way as you think about something like an Impella. But this is a really fantastic area, but rich for investigation and establishing the pros and cons of these devices through trials, rather than just using them because we can. We need to be clear. They obviously have cons associated from a vascular access perspective, and also many other perspectives, as well as potential pros.
Another question I'd ask you both is, how do you protocol drive optimize PCI? I know there's obviously a committee for that in Excel to define the use of imaging. I think imaging is still only 70% in Excel, less than 15% in clinical practice in the United States, but with left main disease, no less. How do you protocol drive, and what are your basic criteria for optimizing PCI?
I completely agree that imaging is important. I think the more that we are conducting these trials with PCI, either compared to medical therapy or bypass surgery, I think we need to start to get stricter about the way that the PCI is performed. I think, if we leave things, up to the operators with no guidance or protocol, then we leave the possibility of having all of these questions afterwards, saying, for example, FAME3, would the results have been different if there was increased use of intravascular imaging? So I would, particularly if we want to do randomized trials in heart failure patients where, we really want to get good outcomes with the PCI that are going to be durable to have a clinical impact, I'd like to mandate the use of IVUS or OCT in all cases. And I also think we should then give the operators a framework for how to interpret them. You can't just say, here's an imaging catheter and you have to put it down. We want to, explain to people what adequate stent expansion is. What are your targets for your minimal stent area at the end? What are your targets for your landing zone? You want to find a healthy landing zone free of disease. What is the plaque burden that is acceptable versus not? So I think once you start to build in some very simple metrics, stent expansion, plaque burden at the distal edge, and then you provide people with a framework, we will then see a translation of improved outcomes like we've seen in the dedicated IVUS trials. I think just saying that you'll use it is unfortunately not going to be sufficient.
There's pros and cons, because if you design a trial which has got absolutely phenomenal PCI in one arm against surgery, then how generalizable is that to the world? The world doesn't necessarily do things perfectly. So they're kind of different trials answering slightly different questions. Is real world normal PCI as good as medical therapy, or as good as bypass surgery, or as optimal PCI? But clearly, we should be aiming for optimal PCI. So I agree with Yousif. Our strategy is to select excellent sites for these trials. So we have investigators who are performing PCI to the highest possible standards, and then documenting that. That's my preference, rather than mandating something. Because if you start taking on sites who don't do things routinely, and as Yousif said, they start just putting catheters down because they've been told to, then it's difficult to learn on the job. They don't really know what to do with the results. It's difficult. So I would rather focus trials on high caliber sites and make sure people are doing the Cabbage as well as the PCI well, or medical therapy. Background medical therapy is crucially important as well. So that's my preference, rather than trying to teach people during a trial how to do proper PCI, just trying to choose a good network of sites to collaborate and try and establish the pros and cons of these different strategies.
Not just impact ischemia-driven TLR. You mentioned BCIS data. Observational data suggests with imaging versus no imaging in left main disease, the survival advantage, correct? Over 2 to 3 years. And so, that can change the primary endpoint of your trial, is to the adequacy of imaging. And in that context, I would ask both of you guys about cardiac death versus all death in your endpoint. You've got a massive trial coming out here, Mark, Revive. Mechanistically, I kind of like cardiac death. Ischemia trial used that as well. What are you using in that trial?
Yeah, we're using all-cause mortality and heart failure hospitalizations. And that's important because people can die after a CABG for non-cardiovascular reasons, and also PCI as well. So heart failure patients have got a lot of comorbidity, so they tend to bleed more. They've got their iron deficiency anemia, they've got renal disease, they've got a whole bunch of things going on. So I'm personally an advocate of seeing how many people are alive at the end of the trial, not just focusing on cardiovascular mortality. But I understand that's contentious, but these people are comorbid and there's lots of competing risks of death. So I'm an advocate of all-cause mortality.
I would, tend to agree with Mark. The purist in me does say that, all-cause mortality, you can't dispute it, and you're not going to introduce, complexities of adjudicating causes of death. And, like Mark said, if you have a patient who bleeds and then you suspend antithrombotic therapy and then they have a myocardial infarction, then it can get a little complicated to tease out. I will accept that, we want long-term follow-up for these patients in these trials. And the longer-term follow-up you do get this problem with competing causes of death. So, I think I like all-cause mortality as the primary endpoint, and then cardiac death is a pre-specified secondary analysis.
There's competing causes of death. And there's the old adage, the dead guy doesn't care how he got there. He's dead either way. But when you actually look at the data following PCI, not only is there competing causes of death over time away from PCI, but over the last 2 to 3 decades, that's been clearly documented that the cause of cardiac death, in fact, the curves cross, cardiac death has declined over time away from revascularization, certainly PCI, non-cardiac death due to cancer or chronic diseases has increased over time. So I think mechanistically, as a purist, I really want to see cardiac death, and I'm glad you're doing that analysis. Yousif, anything else that you would add at this point to your summary? I think this is a very important paper. I think it is the state-of-the-art summary of PCI revascularization for heart failure. And I hope that it will be read and that it will create more interest and focus on this for clinical trials in the future. Now, how would you design those trials, Yousif?
I think that's what our hope is, that, this area is ripe for research and clinical trials, and that, I really do hope that it's incumbent on us as a cardiovascular community to conduct these trials. I think the points you make about, designing and performing these trials in the current era is a little bit intimidating with costs, but some of the things that, Mark mentioned, international collaboration, designing trials that their results can be adequately pooled and synthesized upfront, and pragmatic clinical trials, utilizing electronic health records or lean case report forms, maybe, a way forward to get, pragmatically get some of these trials completed. I'm very much looking forward to the results of Revive this year. And I think the landscape of, revascularization and heart failure is going to change significantly over the next 5 to 10 years with the emergence of new trial data.
Yeah, you make a great point. We really need the trials. To date, most of these data have been observational, and you can do all the propensity score matching and inverse probability weighting. You can do all that you want. There are still variability and subjective more bias than a clear-cut randomized trial. This has been a great discussion. I want to thank JSCAI for providing this platform for dialogue and important topics like PCI and heart failure. I want to thank you, Yousif and Mark Petrie, for giving your time today to record this interview. Thank you very much.